Let's see. Yeah. Okay, so this should be recording now, I believe. Ria, can you try to test the link that I just posted, see if it works? And hopefully that should go good. So just like click on here and also on here. So thanks so much.
What stops you from just clicking on one?
Okay, so this one is because we can't. This is the stream.
Okay,
this
so
is the actual presentation.
Cool.
So yeah, but you can draw if you want on.
Okay.
Is it working, Ria? I'll make sure it's recording. Give me a second. Oh, okay, so yeah, it's recording. And then
Not yet?
I just need to check that the video is working. Start video. Oh wait, it should be. Start camera. Wait, stop. Shit. Stop. Oh wait. Wait. Okay. What about now? Is it working now? Yeah? It's working? So you can see the slides? Okay, cool. Thanks so much, man. Sorry about this.
Okay, hi everyone. Good afternoon. I'm Bala and I'm going to give you guys the renal revision lecture. So what I'm going to do different to some of the other lecturers is that I'm going to encourage active recall as much as possible. I think that's the best way to revise. So what we will do is I'll ask you guys questions, and along the way, please tell your partner or tell your friend what you think the answer is. And then like when I go through the answers to those questions, it will help you guys to retain more information, and that'll be the best way to go for this next 45 minutes. Everybody with me? Okay, great. So, sorry, oh, this, okay, I think I didn't upload the slides, but don't worry, it will come right after. Okay, so now it's just time for active recall. Okay? Great, so what I will do is I'll go through some basics with regards to kidneys and the anatomy and the physiology just for a quick background, so I wouldn't take too much time with that. Okay, so with regards to your arterial supply, I think it's just it's a good idea to start with your aorta, bifurcation, the renal arteries, and then it becomes lobar arteries and whatnot. It's just remember the progression of the arteries. And with the functions of the kidney, this may seem like basic, but why this is useful is because when you think about your symptoms of AKI and your CKD, this is exactly the opposite of what are the functions of the kidney. So later there will be a slide to illustrate this later. And this dreaded picture again. So with regards to this, you've got your fenestrated endothelial cells and you've got plasma leaking through, and you filter all the unnecessary substances from your kidney. So this is the basis in which your kidney works. Okay, so with regards to this, so now I'm going to talk about all the different investigations that is required to assess the kidney function. So now, in practice, you're in an OSCE scenario, and now you know that this patient's got an AKI, maybe it's got a rising creatinine or something like that. I want you guys to tell your partners what are the investigations you want to order for an AKI to assess the renal function. Please, 30 seconds, go. Okay, so I will bring you guys back here again. So, so how I like to classify my investigations is you go via your bedside test, your blood test, and your imaging test. So I started with the blood test. Maybe I should start at bedside. But with regards to blood test, you can say your usuals be your FB, UEC, LFTs, ESR. But the more relevant ones would be your FB, UEC, and your GFR. And can everyone make sense of that? Because the FBA, you're looking for anemia. UECs is obviously looking for a rise in your urea and creatinine. And your GFR it's a good estimation, but there's some problems with that as well. At this juncture, I'd also like to remind you guys that the clearance of creatinine is going to be an overestimation of your GFR because your creatinine is slightly secreted in the kidney. So I'm sure that rings some bells, but just use this time to revisit that fact. Okay, so with regards to the bedside test, which is also your urine test, so that is going to be your albumin creatinine ratio and your protein creatinine ratio with your biochemistry and what we call looking for the urine osmolality and stuff like that. Okay, with regards to ACR and PCR, it tests the exact same thing, but in year 3, I think I was more familiar with albumin creatinine ratio, and PCR is something that you use for pregnant women, and you will come to learn that next year. So just remember these two things. If at any point in time you have any questions, please do feel free to just shout out. Okay, this is something that was a bit challenging. I thought nobody really taught this well. So you've got urine microscopy and urine sediments. So with regards to the microscopy, you're looking for any weird and wonderful things in the urine that is not normally present. So with hematuria, it's important to know what type of hematuria it is. Dysmorphic means that the blood has come from the glomerulus in the little filtration membrane we saw earlier. The blood cells got disrupted, and that indicates to the location of the bleeding from which it's coming down. With regards to isomorphic, that means the red blood cells have not been changed in structure, and it suggests that there is bleeding further down the tract. So that would change your differentials. So if it is from your isomorphic hematuria, you're thinking of cancers, you're thinking of bleeding from the lower down structures. With regards to hyaline cast, that's normal, and okay, and then you've got all the rest which kind of make common sense. Got it? Okay. Then with regards to sediments, when you do some of your EMQs, they will say bland sediment, abnormal sediment, and active. So just know that active urinary sediment suggests that there is some form of inflammatory process, and there is glomerulonephritis, especially hematuria. Okay. Then imaging, I'm sure I heard a few people say cyst and a few other things. So that's a good idea. You're looking for structural abnormalities of the kidney. And for that, you will look for ultrasound. And ultrasound is particularly good because ultrasound is very good at detecting structures where there's lots of fluid in it. So kidney is one structure with lots of fluid. Bladder is another structure with lots of fluid. So as a result of this particular property, ultrasound is investigation of choice. And okay, so indicated for renal biopsy. You can use it for a lot of things. When I was on a nephrology rotation, they use it for lots of different things, but the only thing they don't use it for is when you are sure that the nephropathy is due to diabetes. Lots of people have diabetes. You don't want to torture them with renal biopsies all over the place. Okay. So was that did most of you guys cover all the investigations? Does that all stick in now? Okay, great. So, okay, so with regards to AKI, there's all these fancy criteria you can learn, but I think they're not useful. So just know that as long as there's rise in creatinine, then you are worried about an AKI. And it's similar to the approach we learned in year 2. So that's your pre-renal, renal, and post-renal. Question now, what do you think is the most common cause of AKI? 5 seconds, go, tell you. Okay, so I couldn't hear much, but pre-renal AKI is the most common cause. And like if you have an AKI post-surgery, your most likely is going to be pre-renal AKI. And yeah, okay, so we will go through some of these conditions. Okay, so just to summarize this, pre-renal is a circulatory failure. Renal, there are lots of multiple causes, and post-renal is an obstruction failure. Does that mean obstruction causing AKI? Okay, so that is, yeah. Okay, so now tell your friends, what are the ECG changes of hyperkalemia? Okay, great. So I hear everybody saying peaked tented T waves, but just take note there are lots of other changes as well. So there could be a prolonged PR interval, and there could be sinusoidal waves as well. So this is exactly what they use in cardiothoracic surgery. What they do is to stop the heart and for heart transplant, they give them a potassium chloride solution, stop the heart, and then take the heart and put it in an ice bucket while they transfer the new heart in. Okay, so was that okay? Sure. Then and then with regards to ECG changes, now you've checked whether there is any ECG changes, and now how do you want to manage the hyperkalemia? This would be a very relevant OSCE scenario. Anybody? Please talk to your friends. Go. All right, I'll bring you guys back. So I was hearing lots of nebulized salbutamol and a few other things. So that's the correct response. We will. Okay, so for the question that was I asked earlier, so this would be the summary slide for that. So if you can be familiar with some of these things, so that's going to be very useful as well. Okay, so these are the ECG changes for hyperkalemia. So I don't think you have to know what numbers correspond to which ECG changes. Just be familiar with the ECG changes, that'll be useful. Okay, so this is where you can correlate your functions of the kidney with complications of AKI, and your main purpose would be to manage the complications of the AKI together, and if you can diagnose the etiology of the AKI, that would be fantastic as well. But what's more important is to do these symptomatic relief. Okay, so this is the spiel for your hyperkalemia. So the hyperkalemia, the most worrying complication we have is cardiac arrhythmias, because that will kill the patient. And once we have detected the presence of the cardiac changes, then you do all the rest of the management. Okay, and then everybody talks about resonium. Resonium is, it works slowly. So if you want a gradual correction of hyperkalemia, then you can consider resonium. Everything else acts quite quickly. And the calcium glucuronate, the purpose is to stabilize the cardiac membranes, whereas your dextrose, insulin, salbutamol is to put the potassium back in the right place. So you're not getting rid of the potassium exactly, but what you're trying to do is just put it in a place where it's safe, because in the blood it's not safe. Okay, and the rest is common sense. Okay. Okay, so I'm sorry for this blurry picture, but basically it's a circulatory failure causing AKI. And in this scenario, I think everything else makes sense except what we call renal artery stenosis. So I would go through that. So renal artery stenosis is nothing but stenosis of the renal arteries that is supplying your kidneys. So, and how this presents in an EMQ is that they've got a person who's got high blood pressure, and you prescribe them ACE inhibitor, which is the first line medication for high blood pressure, and they present with AKI 2 or 4 weeks later. So that is a very classic scenario. And yeah, so and then like there's two etiology to it. One is atherosclerosis, so that forms the bulk of it, and a small percentage you get what's called fibromuscular dysplasia. So that's just it affects the distal two-thirds of the renal arteries. I think it's, if you think of a young female with high blood pressure and AKI, think of fibrosis failure. Okay, and yeah, that's all I had to say for this. Oh, sorry. Okay, and then another one where it would be a good idea to think of is what are the secondary causes of high blood pressure. This is a difficult one, but you can just think of it in terms of there's a problem with the kidney, there's problem with endocrine stuff, so that's Conn's tumor, Cushing's syndrome, etc. So if you think of it as renal and endocrine, that would make sense and it will fall in place. So this is your renal risk management. As in, like, this is where I just want to make sure that you just highlight the importance of having a structure to the way you manage conditions in your OSCE. So if you just say, I want to do some lifestyle management, some medical management, and surgical management, that can help you with the way you think and give you more points in your OSCEs as well. Okay, so that was it for pre-renal AKI. Any questions at this point in time? All clear? Okay, so that's where, now is where I will be for exam galore. Okay, so with renal causes of AKI, there is a few ways to group these conditions. So you've got, it's not always glomerulonephritis, okay? So there can be other things. So you've got glomerulonephritis, interstitial nephritis, tubular, and vascular. So we'll go through them in detail at the moment. Okay, so the first one I will talk about is interstitial nephritis. And when you think of interstitial nephritis, all you think of is drugs, drugs, and drugs. Okay, so you've got your triple whammy, if you can remember from year 2. So that's going to be your NSAIDs, statins, and your ACE inhibitors. Sorry, NSAIDs, thiazides, and ACE inhibitors. So that's your triple whammy. And even though they say triple whammy, you don't need all 3 medications to cause an AKI. You can cause an AKI with just 2 of them. And the rest of the this one, it's not very useful, I think. Okay, then yeah, so interstitial nephritis, just remember drugs. And the way on pathology is that it's going to spare the glomeruli, and that's how you know there's going to be interstitial nephritis. Okay, and yeah, that's all I have for here. Okay, so the next one is going to be acute tubular necrosis. So okay, in your buddies, like just go through what the differences between ATN and pre-renal AKI. Tough question. All right. Okay. So we will come back. So I think that was I found it a difficult question at year 3. But okay. So what it is pre-renal AKI is when the kidneys haven't given up yet. That's the way I think of it. And once you've got ATN, the kidneys have given up. So the pre-renal, the kidney is still trying to hold on to the sodium, trying to hold on to the water. But in ATN, the kidneys goes, I give up, I'm done. So I'm just chucking away all the sodium, and that is when they get worse. And on your urine microscopy, so that's when you look for your urine microscopy, you're looking for different casts and stuff, you will find your pigmented granular cast. So that is basically the tubes that are being damaged is being passed in the urine. So if you just logically reason out these 2 conditions, then you'll be good to go for the exams. Okay, with regards to the phases of your acute tubular necrosis, and then for ATN, the etiology is either ischemia, so that is your pre-renal cause, and then or you've got toxins as well. The toxins are damaging the tubules directly. With regards to the phases, there's your initiating phase, maintenance, and recovery. So at this point, maybe I'll just talk about your GFR is not a very good determinant of renal function in an AKI. So the way I was taught is in an AKI setting, you definitely want to look at the creatinine levels and see what they are doing in that episode. Your GFR is always going to lag behind your actual renal function. So if let's say the kidney is getting damaged, the GFR will show a much higher level of renal function than the actual renal function. And in the opposite way, when the kidney is recovering, the GFR would be showing that it's a much poorer renal function than it actually is. Okay. All right, so that's the difference, and I think this is an important concept to grasp. Okay, so with glomerulonephritis, so this is when, like, what I'm going to attempt to do is I'm going to just have a brief basic understanding of what constitutes glomerulonephritis, and then just go through ask you guys the buzzwords for different conditions that you need to be aware of for your exams. Okay, so with nephrotic syndrome and nephritic syndrome, there are lots of mnemonics out there, which is Pharaoh and Leap, and there's too many things. So for me, it makes sense that nephrotic syndrome you can kind of spell protein from there. And then with nephritic syndrome, it's an itic syndrome. So that's an inflammation of your kidneys and of the glomerulus anyway. So with the protein loss, what you're going to have is proteinuria. And when you lose all the protein, obviously you're going to get hypoalbumin. And when you get hypoalbumin, the liver compensates with two things. It produces more lipids and it produces more coagulation factors. It makes logical sense. Okay? So once you make logic out of it, you can remember better. And with the nephritic syndrome, the vessels in your kidneys are the glomerulus is getting inflamed, and therefore you get hematuria. So just hematuria and high blood pressure. So with this, you can clearly say I would be confident that nephritic syndrome is a bit worse than the nephrotic syndrome. So that's something to take note of. Okay, so that is the way I understand glomerulonephritis. And now I have a few scenarios that you might see in your EMQs, and that's when you will remember this lecture and get the answer correct. Okay, so I've got a child who presents with puffy eyes, ankles, and great. What was the answer? Okay, great. So so that's correct. So any child with a nephrotic syndrome is always minimal change, and the pathological findings that you'll find on a renal biopsy is going to be effacement of podocytes. Okay, with regards to renal biopsies, you do three things with them. So just talk to your friends, what are the three things you will do with renal biopsies? Great. I've heard the three things being said. So you do a light microscopy, you do an electron microscopy, and you do a immunofluorescence. So once you do these things, then you will definitely find one of your buzzwords, and you will know, and you will diagnose that person already. Okay, so that's one. That's the easy one. And now I've got a middle-aged man with symptoms of nephrotic syndrome, and he's got a history of hepatitis C. So this membranous. It could be membranous or membranoproliferative, but with regards to okay, cool. So so with regards to any of my nephrotic syndrome, I've got 3M and 1F. It can't be anything else. It has to be one of these four things. Okay. Then with regards to your nephritic syndrome, it's everything else. So I like to go by category. So just this or that. So that is the primary causes of nephrotic syndrome. And with regards to secondary causes, it's a bit sad that you got a nephrotic syndrome. Okay, so you've got SLE, amyloidosis, and diabetes. Okay, so that is your brief overview of nephrotic. And now, if I say thickening of GBM with GBM spikes, what is that? Membranous. And if I say there is a tram tracking appearance, membranoproliferative. So great. So now, so if everybody's familiar with these conditions of nephrotic syndrome, then we can move on to the nephritic syndrome. Does all that make sense? Okay. Now, if I say that I've got a apple green birefringence, amyloid. Great. Fantastic. Okay. And then anybody's heard of Kimmel-Steele-Wilson nodules? Diabetes. Fantastic. And if I've got a full house deposit of beautiful. You guys, I can get out of here now. Okay, so so I'll just so that are all the buzzwords, and even though it's just buzzword based, I think it's so important to have a comprehensive understanding of the condition. So with minimal change, you just treat them as steroid responsive, and with membranous nephropathy, there is idiopathic reasons, or it could be secondary and it's associated with hepatitis C or some form of malignancy. Okay, so that's membranous. And membranoproliferative is a tram track appearance. And you can just read this for your better understanding. Okay, so focal segmental glomerulosclerosis is exactly what the name sounds like. It's focal and it's segmental. So once you see that there are certain areas of the glomerulus that's being damaged and others are spared, then you pick it as an option. Yeah. Okay. Any questions with nephrotic syndrome so far? No? Okay, so these are all your different tables and different things to read about. Okay, so like I said, nephritic syndrome is your inflammation of the glomerulus, and there is lots of common conditions that result in this. And now I've got a 30-year-old female with coke-colored urine and a recent RRT. So this is post-strep. What if I say that the RRT was like concurrent? IgA. So the only difference that I would like to highlight with nephritic syndrome is about IgA nephropathy and post-strep GN. So post-strep is literally post. So you get the symptoms of nephritis 2 to 6 weeks after your sore throat. However, with IgA nephropathy, you can get it with like concurrently. That's the like main difference you will use for exams. And coke-colored urine can mean lots of different things as well. Okay, so I think with post-strep GN, you've like, it's one of those things that is a complication of a strep throat. So you can have post-strep GN, or you could have rheumatic heart fever and a few other things as well. Okay, then the investigations, I'm sure you guys know about ASOT. So it's anti-streptolysin O titer and anti-DNase B. Okay, so so you've got a few vasculitis that result in glomerulonephritis, and that will include your GPA and eGPA. So there are other names for this as well. So what is the other name for this condition? Weakness. And what's the other name for eGPA? Choke straws. Okay, and apparently, fun fact, the name why they changed it was they were the names of Nazis, and they wanted to stop that names. Okay. So that's the fun fact for, okay. And with regards to some of the antibodies with GPA, it's going to be C ANCA, and what's the other one? P ANCA. Great, everybody is, okay. Then, okay, so the upper airway problem. So what is the buzzword that will happen with upper airway problem in this particular condition? Has anybody heard of it before? So it's, sorry? Amoxi? Oh, hemoptysis. Yeah, hemoptysis is one, and you also get a saddle-shaped nose deformity. Okay. So that is this one. Okay. So the only difference with GPA and eGPA is symptoms of eosinophilia. So eosinophilia can give you symptoms of asthma and like those sort of like eosinophil symptoms. Okay. Then. Yeah, I don't think it's very important. Like, you want very high yield to remember all the management for nephritic syndrome, but just make sure that you manage the complications of AKI and glomerulonephritis. Okay, damn. Okay, that's too obvious now. Okay, so if anything to do with linear deposition of IgG antibodies, that's you're going to think of good pastures. So apart from a renal involvement in good pasture, what is the other symptom that you will be thinking that patients present with? Hemoptysis. So that's because they target the collagen, like type 4 collagen, both in the kidneys and in the lungs as well. Okay. So, and that is the end of nephritic syndromes, the ones that is more examinable in exams. Any questions with glomerulonephritis? Everybody seems to be very fluent with your buzzwords now. Okay, any questions, please do ask me. Okay, one more thing. I found it quite challenging. So anybody can, damn, okay, I put all the answers now. So it'll be a good idea to know how linear immunofluorescence looks like and how granular immunofluorescence looks like. And this is the best photo I can find. And like you can appreciate that on the left, it's going to be linear, and on the right, it's granular. Because linear, you've got very few differentials that can cause that. Okay? So with that, I will move on to chronic kidney disease. Okay. So CKD, the way it was defined is an abnormality in the function or the structure for more than 3 months. So that's just a definition thing. As in, it's just good for your understanding. And with regards to staging and describing how bad this chronic kidney disease is, you want to talk about what is their GFR. So in this case, GFR is good, but GFR is only not good in an AKI. It's fantastic in a CKD. So it will give you an idea of how bad your chronic kidney disease is. And it will be also important to talk about the etiology of their CKD, whether it's glomerulonephritis or whether it's diabetes or whether it's any other etiology. And one more thing to take note here, as I'll draw your attention, is kidney symptoms are very rare unless your GFR is very bad. So you're talking in terms of 15 to 20 when your normal GFR is above 90. Okay, so unless it drops that far low, you're not going to have any symptoms of CKD. Okay, so AKI and CKD, it can be very challenging to determine if the symptoms they're presenting with is an AKI or a CKD, if you see them like once. Okay, so some of the things they talk about is the kidney size, renal bone disease, and anemia. Some of these things are very big as well. You can even have anemia in an AKI setting as well. Okay, so the renal bone disease is something that we'll talk about next. Yep, so this is, okay, so these are just not very useful. Okay, so the investigations with CKD and AKI is going to be quite similar, but your etiology that you're trying to chase with the diagnosis may find you to have a few additional investigations. Okay, so so if I was told that with hyperkalemia, if it comes on suddenly, you can correct it suddenly, you can correct it rapidly. But if it comes on slowly, maybe the body is already being used to the hyperkalemia, and if you rapidly correct it, that's going to cause electrolyte disturbance as well. So in CKD, you correct the electrolytes slowly. What? Running out of time, this meeting in 10 minutes. Oh no. Okay. Okay, cool. Then, maybe I'll talk about the renal bone disease at the moment. Oh, this one is stuck. Okay, cool. This one is. Oh, okay, cool. So yeah, the magic hands. All right. Okay. Okay, so maybe I'll talk about renal bone disease. So renal bone disease is something that is specific to chronic kidney disease, and it's not just it doesn't happen in AKI. So okay. So with renal bone disease, there is two primary events that trigger off a renal bone disease. One is that when your kidney is failing, then you are going to retain your potassium, and your potassium, you've got hyperphosphatemia. The phosphate then binds to your calcium and causes hypocalcemia. And hypocalcemia then triggers off an increase in your parathyroid hormone. So that is called secondary hyperparathyroidism. Okay, so and these two mechanisms will then cause like your osteoclastic activity and cause, as you want to replace the calcium levels in your blood, and you cause damage of the bones as well. Okay, so there is a spectrum of disease. So they call them adynamic bone. So adynamic bone, normal, and you've got osteitis, fibrosis, cystica. So you've got all these renal bone disease, but in OSCE, just ask them, do you have any bone pain? Okay, so that would give you an idea of CKD. And with regards to, and then in parathyroid hormones, so if I've got hyperparathyroidism, do you all know what a primary hyperparathyroid is? Okay, adenoma, great. And then you've got secondary. And what's the difference between secondary hyperparathyroid and tertiary hyperparathyroid? Sorry, tertiary is caused by. Okay, I think you guys know this, but it's just that when your secondary hypercalcemia, your parathyroid hormone is responding to the hypocalcemia. Tertiary is when there is no longer any more stimuli, there's already hypercalcemia, and the parathyroid hormone is still secreting, like there's no regulation. So that's the difference, it'll be important to know. And yeah, so now we've talked about managing complications. So this would be, okay, now tell your friends, what are the different indications of dialysis? Beautiful. That was the exact mnemonic I wanted as well. So AEIO is acidosis, electrolyte disturbance, and what is I? Yeah, so I is yep, and then O is overload, and U is uremia. So uremia, then I've got this other mnemonic where uremia starts with anything that is P, so it's platelet dysfunction, pericarditis, and peripheral neuropathy. Okay. All right. So this was the hyperparathyroid. Maybe it will be. I've explained this already. Any questions regarding this?
What was the I for?
Let me think. Here we go. So I is intoxication. Okay. So these are the and then if you will also dialyze if medical therapy doesn't work. So that's another obvious one. Okay. So and okay, maybe I'll talk about what we call renal replacement therapy. So these are all the management options for AKI and CKD. And what you have is you've got hemodialysis and you've got peritoneal dialysis. So okay, so with hemodialysis is the dialysis that we all have heard of before, and what it involves is that you have an AV fistula. So an AV fistula is the connection between an artery and a vein. So you and then like you use that high flow venous high flow circuit to dialyze. So you remove the waste and you put in all the different things you need to put in.
Are there more people available to help remove the food from any outline? Thanks, guys. Just, so I'm just going to be there. I need to get to change the recording, but I'm just going to be there and to move over to the front. Thanks, guys.
All right, so that is the motivation for the last 15 minutes. Okay, so now with regards to the dialysis, then you've also got a peritoneal dialysis option. And that one is just using the peritoneal membrane as your semi-permeable membrane to get rid of the waste. And okay, so one thing like we don't know much about like peritoneal dialysis, but one of the complications is that you can have peritoneal PD peritonitis. So that's when the membrane gets infected, and the patients have to be admitted for antibiotic treatment and to find some of and to treat them well. So yep. So and then like one of like there are lots of different complications with hemodialysis, and some of it is like the main idea is they have to come into hospital and they will stay there for about 4 to 5 hours. It's a long process. So if you do it any faster, then they will have all of these. They are high risk of these complications. Okay, so now one question. So in a patient with renal transplant, how many kidneys do they have? Great. Okay, I love you guys. Okay, so so I think like renal transplant, you don't have to know much, but it's a very commonly done transplant procedure, and it's usually put in the right iliac fossa. They leave the diseased kidney there, unless they've got cancer or unless there is some form of like they leave the old kidney there. Okay. So I'll just okay. So that is all with the kidney stuff. So now maybe we'll just talk about a few other simple things. So this is one of it is going to be UTI. So what is the most common cause of UTI infection? E. coli. Great. And okay, with regards to so a UTI is a lower urinary tract infection. So what is it called if my infection goes all the way up to the kidneys? Pyelo. So what are some signs and symptoms of a pyelo? Sorry. So okay, wait, no, okay. So wait, okay, wait. Before we go to the pyelo, sorry, I got a bit excited. Okay, so UTI, the main management is trimethoprim, and like you don't use it for pregnant women, but I guess you don't know that now. And yeah, so this is easy. With pyelo, the ones I was hoping for signs is you want to talk about your Murphy's kidney punch and your tenderness with at your costovertebral angle. So these two signs will suggest that the infection is at the level of the kidneys, and then you have to treat your antibiotic regime a bit differently. So with UTI, it's just going to be one antibiotic. It's a simple antibiotic. But with any of the pyelonephritis, it's going to be more powerful antibiotics. So that includes your ampicillin and gentamicin. It's very similar to your empiric antibiotics for any gastrointestinal perforation. So that's your AMG, but you remove the metro because you don't need you don't need anaerobe cover. Okay, so if you can make sense of your what antibiotics for what cover, that will help you heaps. Okay, so with reflux nephropathy, there's only there's only very few ways they can ask this in the exam. What they will say is there's this 20-year-old female with got a recurrent UTIs in her childhood, and now she presents with some form of renal damage. That's usually due to reflux nephropathy, and it's a surgical problem in the sense that your ureters are coming into your bladder at a wrong angle. So instead of coming in vertically, they're coming in horizontally. So that makes it easier for your urine to backflow, causing stasis and therefore causing infection. So that's all for reflux. And any questions regarding any of those conditions? No? Okay. So this is a year 2 classic, but okay, we don't have to go through this, okay? So it's just 3 constrictions of the ureter. And now, renal calculi. So Abhishek went through some of the composition of the gallstones. It's very different to the composition of the renal stones. And I used to get a bit confused, but this one is just calcium oxalate and there's a few other things. So there is one thing for that you can remember about each of the stones. Calcium oxalate is the most common type of stones. Struvite is associated with UTI. If they've got multiple infections and they've got a stone now, that's usually struvite. And uric acid, it's the one, no, I think cysteine is the one that's got a family history of those stones, and uric acid is just uric acid. Okay? So, and yeah, this is like the way that one of the urologists described this pain is that it's a pain that makes grown men cry. So it's a very horrible pain, 10 out of 10 pain as well. Okay? Okay. So with regards to investigations, I'm sure you guys know this. The